अऊज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अर्रहमान अल्लमल कुरान खलक़ल इंसान अल्लाहुल बयान। आज फिर कुछ दिनों के बाद आपसे बात कर रहे हैं। हमेशा की तरह बात शुरू करने से पहले एक इम्पॉर्टेंट बात, सक्सेस ऑल डिपेंड्स ऑन द सेकंड लेटर एंड दैट इज़ यू। पास होना, फेल होना, पढ़ना ना पढ़ना, इट ऑल डिपेंड्स ऑन यू। So the more topic of today's talk is small head. This is the topic that you come across very frequently in your clinical exam or especially in day-to-day practice. So आपने शुरू करना है small head like command. So this child is having a small head. Please do the GP and relevant. So after the introduction and consent, there's a hand sanitization and exposure. Ideally, the child should be in a single shots. Then, as like in all examinations, general look, sick looking, well looking, nutritional status, pallor, jaundice, diagnostic and dysmorphic features. So these are the things you will check it. After that, you do the anthropometry, where will be the decrease of occipital circumference and markedly decrease height and weight. So, if all three are degrees of malnutrition is there because of relative sparing of head. If the all three are proportionately decreased, there must be syndromes or panhypopituitarism. After that, you do the inspection for dysmorphism or any visual impairment such as the child is wearing glasses. Then you look for the head shape. While the child is sitting up, palpate the anterior fontanelle if wide, congenital rubella syndrome or the trichomes. If there are overriding sutures, there can be craniosynostosis, which is a premature closure of the sutures. Then, if there is increased anterior posterior diameter, this means that the sagittal synostosis is there. If there is increased transverse diameter in high walled, there is a coronal synostosis. If it is asymmetrical, then is a unilateral lambdoid. Narrow forehead and mid forehead raised in metopic. So this is the pictorial representation. See the a long anterior posterior scapulocephaly, which is due to sagittal, then metopic due to tracheocephaly, trigonocephaly, and then is a unicoronal plagiocephaly, then bicoronal brachycephaly. So these are the different weight shapes of the head. You must memorize them. And then there's a sagittal corosynostosis. You see sagittal suture is and the anterior posterior diameter is increasing. And this is a shape sagittal craniosynostosis. Then unilateral coronal synostosis, atypical shape of the head. Then there's a positional deformity. You must differentiate in a position, the sutures will be not fused, while in the synostosis, the sutures will be fused. So then look for the hands for polydactyly, rudimentary thumb, which is present in case of Fanconi, pulse, respiratory rate, BCG scar, axillary lymph nodes. So there are types of polydactyly like preaxial, which is before the thumb, central, and then there's postaxial, that is on the ulnar side. Then there's a rudimentary thumb. There will be no bony connections with the hand. Then you check the eyes for upward slanting, which is present in the Down syndrome, downward slanting in trisomy 9, hypotelorism, holoprosencephaly, cataract, squint, and nystagmus. See, there's the upturned or up slanting and down slanting eyes. Then there's a cyclope. This is the different position of the eyes. You have to measure it like cyclopia, partial cyclopia, single eye. Then hypotelorism, then normal, then hypertelorism, which is increased distance. So this is the method to measure the total interpupillary distance, intercanthal distance, and you should know the normal values. So this picture A is showing the normal, whereas the picture B is showing the hypertelorism. Then nose, the saddle deformity is occurs in syphilis, as you see in the picture, prominent in the Sacral syndrome at the midline groove in holoprosencephaly. And you see the Sacral syndrome like a bird-like appearance. Then there is a holoprosencephaly. Then you check for the hearing impairment for the torch, spine, scoliosis in degenerative brain disorder, cardiovascular system for the torch or trisomy which have the associated cardiovascular abnormalities, abdomen for the liver and spleen that can be enlarged in case of the torch infection. For the motor examination, you check the upper motor neuron signs which are present in cerebral palsy and degenerative brain disorders, whereas the lower motor neuron signs are present in Cabet disease. Cerebellar signs are present in cerebral palsy, Pelizaeus, Merzbacher disease. After that, you have to learn the developmental assessment, that is a 180-degree examination. I have made a therapeutic the hypothetical description, that is, Assalamu alaikum sir or ma'am, I've just examined 3-year-old Junaid who was conscious and cooperative during my examination. He is sick looking undernourished child without obvious respiratory distress and cyanosis at rest, and there are no diagnostic or dysmorphic features. He has obvious microcephaly with OFC of 42 centimeter. So he has an obvious microcephaly. Previously, there was accidentally microcephaly written with OFC of 42 centimeter, height of 75, and a weight of 10 kg, which all seems to be less than his age. But I would like to plot on centile charts. His pulse is 80 per minute, respiratory rate is 25 per minute, and is afebrile to touch. His head shape is normal, and the anterior fontanelle is closed. The motor system revealed hypertonia, power of 3 by 5 in the lower limbs and 5 by 5 in upper limbs, with exaggerated deep tendon reflexes and upgoing plantars. The gait of the child cannot be assessed because he is unable to walk. There is no clubbing, koilonychia, leukonychia, palmar para, or erythema. His BCG scar is present. There is no pallor, no lymphadenopathy, no abnormality in eye examination, and normal hearing, and there is no hearing aid present. The heart sounds were normal in all areas of auscultation. There is no hepatosplenomegaly, and the spine is normal. Child developmental age is 6 months and is only able to sit unsupported. Based on my clinical examination, the child is most likely having a cerebral palsy. So the differential diagnosis can be cerebral palsy or torch infections. And the causes of the microcephaly can be like the primary genetic causes, then familial autosomal recessive, which have the typical appearance like the slanting forehead, prominent nose and ears, and mental retardation. Then the familial autosomal recessive syndromes like trisomy, Cry-Duchar, Cornelia-de-Lange, Robin-Syntemy, and Smith. These are the syndromes that are associated with microcephaly. Then secondary causes of microcephaly are torch infections, fetal alcohol, fetal hydantoin syndrome, radiation, HIE, hypothermia, meningitis, encephalitis, oblique meningitis, malnutrition, metabolic phenylketonuria, degenerative brain disorders such as Rett Krabbe's, neuronal ceroid lipofuscinosis. So what are the investigations like CT scan, MRI, torch, karyotyping, and metabolic workup? So this is a child with a congenital rubella syndrome. So thank you very much for listening. Remember, this is just a guideline for you. The aim is to teach you, to give you some idea, but you can do as much as you like, and you can change it, improve it, and you must give me your feedback that this is what else you want to hear from us. So I pray that may Allah be our protector, our helper, and guide, and best wishes for you. Allah Hafiz.